Good evening. Thank you all for joining me here tonight for the ASRA Hot Topics webinar, where we'll be discussing pain management via regional anesthesia and acupuncture in veterinary species. A couple quick updates before we launch into the presentations. There are a few upcoming events that really I think are worth checking out and are something that you should consider planning to attend. Number one, the 22nd annual pain medicine meeting is scheduled for November 10th through the 11th in New Orleans. The abstracts are due August 15th. So if that's something that you are considering, now is the time to get started on working to put those together and have them submitted. There are two courses that will be held here very soon then as well. The Introduction to POCUS course will be held September 23rd through the 24th in Salt Lake City. And then the ultrasound guided regional anesthesia cadaver course will be held October 7th through October 8th in Chicago, Illinois. Now, one thing to bring up here is that in the course of the presentations, if you have any questions, please type those questions in the small text box at the bottom. And when you're finished typing up your question, make sure that you click that send button. At the end of both presentations here tonight, we'll be reserving approximately 10 to 15 minutes to address your questions. And please note that due to some time constraints, we may not be able to respond then to all of the questions that are submitted. So we have two presenters here tonight then. First, Dr. Carrie Schroeder will be discussing Comfortably Numb, regional anesthesia in veterinary medicine. Dr. Schroeder is a veterinary anesthesiologist from the University of Wisconsin School of Veterinary Medicine. She completed a residency at that University of Wisconsin as well, and then never left the beautiful city of Madison. Her clinical and research special interests include regional anesthesia and anesthesia of non-domestic species. And then in addition, she served as the co-editor of the newly released edition of Canine and Feline Anesthesia and Coexisting Disease, and is currently a co-editor of the new edition of Lum and Jones, Veterinary Anesthesia and Analgesia. After Dr. Schroeder, then Dr. Snyder will be discussing acupuncture in animals. What's the point? So Dr. Snyder attended veterinary school at Kansas State University before going to the Ohio State University to complete her residency training. She has been at the University of Wisconsin since following her veterinary training and has really done a phenomenal job here establishing a chronic pain acupuncture type clinic where they can address long-standing pain issues that exist in a variety of different animals. And with that introduction, so that we can get to your questions at the end then, I will turn this over then to Dr. Schroeder.
All right. Everybody can see my slides? We're going to go ahead and say that's the yes. Thank you guys so much for having me here, and thank you so much for joining. This is a great topic to talk about. It's one of my favorite topics, actually. Now, I have to say this is really difficult to talk about. Not that it's difficult to talk about this topic, but this is really difficult to distill this down to 20 minutes. So we are going to treat this in the most superficial of superficial, sadly, but please, please, please don't hesitate to reach out. I'm very available via email. If you have any questions beyond this webinar, please go ahead and reach out to me or Dr. Snyder. Okay, so what is veterinary anesthesiologist? Dr. Snyder and I are DVM specialists. We completed a 1-year internship. You can also do a practice equivalent, followed by a 3-year residency. Currently, there are about 23 programs in the US and then a couple internationally. We work on every species and we work with every procedure. We generally don't subspecialize. So you're not going to see something like a regionalist or something that's doing transplant, neuro, anything like that among anesthesiologists. So we can come in, we can work on a dog, we can work on a cat, bull. Sometimes we get called to the zoo for something like this. This is a tiger that had a root canal. So this is just airway management of a tiger. You can see all the way down to the tracheal rings. We work on every species, every size, you name it. And that is not without its challenges. As you can tell, we have a hugely wide diversity of species. So mammals represent over 6,000 different species, while birds and reptiles are about 10,000 each. Now, will we work on each one of those in our career? Oh, heavens, no. But we need to be able to adapt to each and every one of those species, sometimes at, just not necessarily moments, but a couple hours notice. all these animals and all these species have pretty wide differences in anatomy and physiology, as well as pharmacokinetics and pharmacodynamics of drugs. And sometimes we'll just have to kind of go to related species that have published data. For instance, if I'm presented with this tortoise that needs anesthesia, and there's nothing in the literature about XYZ in red-footed tortoises, well, let me see, is there something about a sulcata? Or is there something about a turtle, something like that, where we can go to something somewhat related? Now, fortunately, the anatomy of nerves is relatively well conserved, and the efficacy of regional anesthesia and regional anesthetic techniques is fairly well conserved. An example of this would be neuraxial techniques. As you'll see in a little bit, we can do spinals, epidurals in a huge variety of species. Right here, we're showing one of our ZooMed residents performing an epidural in a tegu. Okay, so let's launch into this by talking a little bit, maybe a slightly deeper dive into a very common case that we'd see at our clinic. So this is Drago. He's a 5-year-old male German Shepherd dog that weighs 40 kilograms. So this, what you'll usually see when we're presenting a case is obviously age. This is pretty similar, obviously, to what you guys would do. But there's oftentimes the qualifier of male neutered, male intact, spayed, female spayed, things like that, because we do need to know their reproductive status, because altered animals can present slightly differently. In this case, this is an intact male who has plenty of testosterone running through his veins because he just needs to do a job. He's presenting for a right cranial cruciate rupture, as you would say an ACL, an anterior cruciate rupture, coming in for right stifle, arthroscopy, stifle being knee, and a TPLO. So this would basically be a right ACL who needs to get his knee scoped and undergo surgery. His physical's normal, his history is unremarkable. We do know that he's a police dog that works for a living doing narcotic sniffing, bite work, things like that. So first and foremost, we're going to be concerned about his safety, but really personnel safety as well, both pre and post operative. This is a job. This is a dog that has a job. These are amazing citizens that we work with, but they are somewhat dangerous. Fortunately, they come along with handlers that know how to work with them very, very well. So we can administer preoperative sedation, IM, intramuscular, and then they're really easy to work with. Then they're just kind of a regular dog for their intra-op course. In this case, we had the handler put on a basket muzzle. We gave him dexmedetomidine and hydromorphone. In his case, 40 kilograms, we gave 4 milligrams of hydromorphone, 200 micrograms of dexmedetomidine, and it sedated him really, really well, enough to facilitate placement of catheter, propofol, direct laryngoscopy with intubation with a size 14 endotracheal tube, and maintenance with isoflurane. We'll talk about sedation in a little bit, but this is one that we'd want to preoperative or preemptively sedate for recovery for everyone's safety. Now, just like you guys, we really worry about their pain intra-op, and we have a few options for his analgesia. Certainly, we can rely on systemic analgesics, so we could do ketamine, opioids, lidocaine, pretty much anything that's available for the human side of life. However, we want him a little bit more alert after the immediate post-operative course. We want these guys somewhat up and at 'em and ready to move, hopefully ready to go home. And along those lines, that might rule out a neuraxial technique. Pretty much any hind limb procedure and abdominal procedure, we can do neuraxial techniques. While thoracic epidurals are an option, they're less commonly used. More often than not, you're going to do a lumbosacral epidural. And as you can see here, we can do neuraxial techniques in any number of species. This is a morphine spinal in a turtle, a lumbosacral epidural in a dog, and then a lumbosacral epidural catheter in a young calf. But in his case, like I said, we want him up and moving, and we want him not to have significant weakness so he can go home with his handler safely. So we're going to choose a peripheral block. All right, so this is just one of the blocks we do right here, obviously not him, but you could see us doing a sciatic block. This is one of our older ultrasounds that we used to use, and you can see that sciatic nerve right there, and we're going to see that a little bit better on the next slide. Here's one of the published dermatome slides. The coverage is going to be pretty similar to humans. As you would say, lower extremity, we would say hind limb. Dermatomal coverage is pretty darn similar and pretty well conserved between humans and some of our quadrupeds. They're just going to be a bit smaller, and the muscle mass is going to be a little bit differently distributed. Upper extremity anatomy is going to be very, very different. We're not even going to go into that tonight, but just because our animals depending on the species, are often meant to walk on their forelimbs. They lack clavicles. There's just some differences that we have between species where hind limb anatomy is going to be pretty well conserved. You can see our sciatic dermatomes come to the lateral, where femoral dermatomes are more medial. So here we have our sciatic nerve block. This is published elsewhere. Somebody had a really nice figure. And what you can see is that we have that probe kind of on the mid-femoral region. And then we approach with our needle from the caudal or caudad direction. You can see that the sciatic, the two branches, live right here where we can administer our infiltrate. So this right here shows electrolocation. We typically don't accompany nerve stimulation with the sciatic block. Well, we certainly can just to verify placement, but you can see this is a pretty obvious target and we generally have no problem hitting it. And as you know, this is a very, very effective technique. Femoral block, again, going to be pretty darn similar. You'll notice that I would imagine these are going to be much smaller than in human patients, but we're going to go ahead in the femoral triangle, find that femoral artery. And I can say that it pretty much never looks this good. I don't know if I'm doing it wrong, but it doesn't look this good. This is a great image of the femoral nerve, but more often than not, we're going to accompany that with a little bit of electrolocation so we can verify that femoral nerve, because oftentimes it kind of just looks like this hyperechoic blob, just deep and slightly cranial to the femoral artery. However, just like in humans, we're going to get a little bit of quadricep weakness if we block out that femoral nerve fully. So we're going to try for just the saphenous block in this case. So we're going to go a little bit distally down the femur, find our femoral artery, that nice triangle cranial to the artery, and then we'll approach with the needle from this direction. If you can see hopefully you can see my cursor. All right, and in this guy's case, he did great. He had no pain. He needed no additional opioids. We did want to preemptively recover him, as I said. I'm sure you that work with humans are used to emergence delirium. You know, this would be analogous to maybe a football player or something like that. Somebody that could maybe come out a little bit delirious and be a little bit of a danger. So we give him 1 microgram per kilogram of dexmedetomidine with some carprofen just for additional analgesia. And then what we'll do is place this basket muzzle. This is very comfortable for him. He's used to wearing it. This is something that police dogs do. He has full range of motion with his mouth. He can open it fully and we can actually extubate him through that. And he did great. Everything went really smoothly with him. Okay, so that was just to kind of give you an idea of what we do. Now we're going to treat some of these cases a little bit more superficially just to highlight some points. So in this case, this is BD. BD is a 3-year-old spayed female Labrador, and just like all Labradors, they are garbage cans. And BD is no different. She has a 2-day-old history of vomiting and lethargy, and just kind of this vague history of eating a toy. Abdominal radiographs showed this something that is not supposed to be there. And when you probe the history a little bit further, you find there's a young child in the house that loves Gabby's dollhouse and specifically loves this toy Keiki that recently went missing. So BD is going to need an open laparotomy to get Keiki taken out. We're going to do kind of standard anesthetic techniques, but for abdominal wall analgesia, we're going to do a rectus sheath block. This is a fascial plane technique that was adapted from human medicine. And because we do so many open laparotomies, you can see that this dog must have had a history of this with that scar right there. We do a lot of these and they are so effective. We did the first veterinary cadaveric study of the rectus abdominis or the rectus sheath block. And you can see right here, head to the left, tail to the right. You've got your transversus abdominis muscle on the bottom, and then that rectus abdominis muscle pulled away. And you can see that methylene blue as we're testing it with a cadaver, really bathing those ventral nerve roots. We've got some proprietary data up here. We've done a recent CT study with rectus sheath block compared to tap block, where we just injected CT contrast medium into the rectus sheath, just the same technique to see where it goes. And you can see that it stays very nicely in that rectus sheath. And I will say this is a wonderful block that we've started using clinically. Our surgeons love it. So let me take a brief interlude kind of related to fascial plane blocks. So going way back to about 2009, when I was a resident, we had this lynx come in that ironically ate a toy and needed an open laparotomy. It just so happens that I had an anesthesiologist down the road who brought me lunch. And he said, well, there's this kind of new block called a tap block. Let's try it. And lo and behold, we did the first fascial plane block in veterinary medicine. So you can see this was the published image, and these are all obviously kind of old images at this point in time, but C represents the transversus abdominis. And then we've got the internal and external abdominal obliques. with local anesthetic kind of in that tap plane like we want. Lynx did really well. We don't know what his pain scores were. It wasn't safe to perform, but roughly 6 to 8 hours afterwards, we like to think it worked, because that 6 to 8 hour mark when the bupivacaine started wearing off, it bit the owner. So we like to think it worked. But we subsequently started pioneering far more fascial plane blocks in veterinary medicine. So here we are having an erector spinae plane block and a tegu. We had some cadaveric studies in dogs with the ESP. Here we are, the pectointercostal fascial plane block. Here we did it with some cadavers. Up here is with a clinical patient. And some of our surgical colleagues have reported that that is a very, very effective block for sternotomies. And then more recently, we started looking at the external oblique intercostal block. We did this in rabbit cadavers, where you can see that plane where we've got the needle coming in, and we injected methylene blue to look at the spread. And we think, based on methylene blue spread, that it's going to be really effective. However, it was a fairly small target, so we decided to see how that worked in horses. So here you can see in a clinical patient that we were seeing how it works in a standing horse. The tape marks off rib spaces. We've got a nice shave spot for the ultrasound. And this is our resident Emmett using kind of a modified algometer. It's a pipette tip on a stick to basically see dermatomal coverage, to see when this horse would react. And it just so happened that she reacted by kicking all too willingly. Okay, this isn't just for our benefit. We also work together with the residency program at University of Wisconsin. So this was a recent issue of our On-Call magazine that highlights this program. And Chris Darling, the residency program director at UW Health, says that this is huge from a recruitment standpoint. This partnership that we have between the human and veterinary side is really powerful. There are many, many ways that this works, and it's very mutually beneficial, and not just locally. We have a nationwide drug problem. We have obviously an opioid crisis, but we're kind of on the precipice of another crisis, and this is the release of this tranq dope. So if you read on beyond tranq dope, any veterinarian that's ever worked with a large animal will know what xylazine is. This is something that we use extremely commonly in large animals, and we know this drug backwards and forwards. It's something I use for pretty much any large animal anesthetic. So we can work together as One Health to discuss what this is, to educate veterinary practitioners and human practitioners, to discuss, hey, on the veterinary side, we have reversals, and these reversals work really, really well. We've got atipamezole. These discussions need to be started before it's too late. So done with that interlude, let's move on to some more species challenges. So back to that EOI in a horse. So it turns out a fascial plane block in a standing horse, gravity is a little bit your enemy. So that external oblique intercostal block, when we put right there at about T10, turns out it just sunk straight down. But the interesting thing is that you can look on thermography and you could see exactly where that dermatomal coverage was. It just lit up with just heat. And horses are one of the species that we have that sweats, and we have this nice sweat stain going perfectly down. So while the EOI was a little bit of a fail, we learned that, turns out you can get some surrogates for dermatomal coverage besides just kind of poking them. Horses are one of our slightly more difficult species in that they need all the motor we can get. So we cannot really do peripheral limb blocks on these guys because they can't tolerate any loss of motor function. What we do, on the other hand, is we'll do a lot of epidural catheters. This is right here, a lumbosacral catheter in a horse that had some pretty severe hind limb pain. Now, we of course can't do local anesthetics there because this is what happens when a horse can't support their weight fully. They need everything that they can get, so we can only do morphine epidurally. And here we have this right here. I'm going to talk over this. You can see this is kind of getting to be an older video. This is when we were shut down with the pandemic and before we realized that we had to be wearing medical masks. But you can see the horse sadly isn't standing very straight. This isn't uncommon because oftentimes they're a little painful. We're feeling that lumbosacral space. There's pretty heavy muscle here, and we're going to go in with that Tui needle. There's going to be a lot of drag with that, just pretty thick skin and pretty heavy muscles there. We do things just a little bit differently. Well, we can use the same technique to find the space and loss of resistance as human medicine. We tend to use a hanging drop technique. So you can see kind of tapping on the butt just to distract her a little bit. They don't really understand that, oh, there's going to be a little poke here. So we put a little bit of saline in the hub of that needle and just, sorry, the wings of the two we broke. But we're going to advance forward. And what we're looking for is that loss of resistance as found by a hanging drop of saline. You can't see it perfectly here, but as soon as it penetrates that ligamentum flavum, not only will you feel that pop, but that saline in the hub of the needle will kind of fall down. These guys are so big that sometimes we'll kind of put our finger over to not have them entrain air. And then we can go ahead and feed that epidural catheter. Okay, so we have our challenges in our fairly large animals, our large domestic species, but then we have pretty significant challenges with our very, very, very large species, and that's some of our zoo animals. This is case number 3, Stretch. In this case, names and faces have been changed to protect the innocent. Stretch is a 2.5-year-old male giraffe. This is a different giraffe, sadly, presenting for right hind limb lameness. What he was doing was kind of locking his knee. The surgeons thought what it likely was something called upward fixation of the patella. But what we had to do is fully immobilize him. So he needed a general anesthetic with accompanying radiography of the knee and then plus or minus surgery. So this is a whole topic unto itself. This is more than a webinar. This is a full lecture on giraffe anesthesia. So we're not going to get into it. Again, names and faces have been changed to protect the innocent. This is actually a giraffe in Miami, but you can see how complicated and labor-intensive giraffe anesthesia is. We need to be very, very, very cautious of that neck and the muscles associated with the neck. And you can imagine how they need all the motor they can get. They need every little bit of strength and brain power that they can muster to get that whole body, that neck, the long legs, and everything up. So just some of the concerns that we have certainly are ventilation. Again, this is regional anesthesia, so I'm not going to get too far into it, but you can see that there's a tremendous amount of dead space that standard ventilators won't really work very well. So this is something called the Zubinator. It uses a large oxygen cylinder, kind of like a regular old Hudson demand valve, but then it will entrain ambient air to just give that little boost for ventilation. And so we were able to hand ventilate him throughout the procedure. Now, he was immobilized with an ultra-potent opioid, in this case, thiofentanyl. So we can't keep opioids on board for analgesia because that had to be reversed at the end for him to stand. So he had challenges associated with his regional anesthetic because we can't do ephemeral sciatic, we can't do a saphenous sciatic. We can't do really any regional anesthetic technique. We had to rely on local anesthetic techniques. So with all of our animals, we have to be thinking about this balance of, can we do a regional anesthetic? Is it safe? We have to then kind of work around that and then come up with a plan as a team. And in his case, he had a nice NSAID. And then here we are with Dr. Snyder. And then you can see our surgeon just doing basically a local block around the surgical site. But the good news is he woke up beautifully. He was very comfortable. So while we didn't use regional anesthesia in him, a just solid local anesthetic worked. But we also use some interesting adjunct techniques, which is the perfect segue into Dr. Snyder. So I'd like to introduce Dr. Lindsey Snyder.
Thank you so much, Carrie. And now we do the changing of our screens. Here we go. Excellent. And I assume if you cannot see my screen, you will let me know. Otherwise, I will get started. I will finish with talking about the giraffe because we did use acupuncture with the giraffe. It should be noted that I am an anesthesiologist. So that is my training and that is where I spend most of my time. But I also have acupuncture training as well. And to get into my acupuncture training a little bit, this is actually from a study that I did during my residency at Ohio State. We would come in and they would give us a master's project. So I just got a project that someone needed to be done. And it happened to be looking at acupuncture, electroacupuncture, and a transcutaneous cranial electrical stimulation and their effect on the MAC of isoflurane in dogs. The figure that you're looking at now, those are the points that were used during my master's project. And I actually went into my master's thinking, I don't want to do this. I don't believe in acupuncture. I don't believe that a needle on your back leg can somehow regulate your GI tract, things like that. And what actually wound up happening is that through my master's project, I became a believer, because I actually proved in my project, and the results were published. But acupuncture, electroacupuncture, and this transcutaneous cranial electrical stimulation all decreased the MAC of isoflurane in anesthetized dogs. And we did use some things to try and tease out whether it was sedation or analgesia. Nonetheless, we reduced the MAC in all these cases. And so I became a believer, and that started my journey towards actually becoming certified in acupuncture, as opposed to just learning the specific points that were required for my master's. So that's a little bit of background of how I was introduced to acupuncture. But what is acupuncture, and why do I like talking about it so much? Why do I like talking about it to the medical community? It kind of just goes back to some of the science behind it. So the definition itself is that it's acupuncture is the stimulating of specific anatomic points in the body to produce therapeutic or analgesic effects. So not only can we have analgesia produced, but we can also have therapeutic effects with, again, for example, the GI system. The stimulating of those anatomic points does not have to be through the use of needles. So usually we talk about the fine gauge needles that are used to puncture the skin. But acupuncture, that's kind of the traditional mindset. You can actually stimulate those points by different methods. So you can use heat, pressure, aqua, electro. So here on this next slide, on the upper left-hand side, you can actually see that there is heat being used to stimulate a point. So there is an herb that burns very warm, sort of like incense. So mugwort is used and can be used to stimulate the points. So you can either use a moxibustion stick, like is being used over the human, to stimulate those points, and just the warmth over the point itself can stimulate the acupuncture point. Or like on the bottom left-hand side, you can actually add that herb to special needles where the needle itself will get warmed and stimulate the points in that way. It's not something that I do in my practice for two reasons. The first is, if you look at that bottom picture, if you imagine lots of hair and potentially straw and hay around something that burns very hot, that's not an ideal situation in my book. Second is that mugwort actually smells a lot like marijuana, and that's a difficult one to explain to owners as they come into a medical clinic. So it's not something that I incorporate. Other things would be just pressure. So acupressure, the point in the middle on the top is a point that is used for headaches. And it is one that oftentimes you'll see people kind of pushing this point because they've been taught to do that to help with headaches. And it's a master point for the head and face. In the bottom middle is using acupressure with seasickness bands on a point that actually has been proven to have a significant influence on nausea. You can also use aquapuncture, and there are many different types of aquapuncture. You can inject vitamin B12 into acupuncture points. You can take the patient's own blood and inject back into an acupuncture point, which is called hemopuncture. You can do pharmacopuncture, where you're actually injecting small amounts of drugs or medications into acupoints to achieve that stimulation of the acupoint. And then lastly, we can use electroacupuncture, which I'll speak about a little bit further as I go on. So acupuncture, even probably 20 years ago, was much more poo-pooed than it is now. Now it is showing up on very prestigious websites. Johns Hopkins Medicine has information on acupuncture directly on its website, and pointing out that it's part of the practice of traditional Chinese medicine. Additionally, the NIH has information on their website directly about acupuncture. And what I find interesting about this is one of the questions or some of the disbelief I still get from some of my colleagues, people saying, I'll believe it when I see the literature. Well, the literature is out there. You might just not be looking in the right place. The following ailments have all been proven to have success with acupuncture as a treatment. So this is sort of getting into some of the therapeutic effects of acupuncture, including addiction and asthma and nausea. So some of those therapeutic, and then of course pain with all the ailments that are listed that have pain associated with it. So why recommend acupuncture as part of any sort of treatment modality? Well, acupuncture is virtually devoid of side effects. We can't say that they are completely devoid because there are situations where acupuncture is contraindicated. And as with any modality or therapy that we introduce, it may not be universally effective. And whereas in other cases, it might be the only thing that you need. So some people, when they're very painful, they will need a combination of an NSAID and a narcotic, whereas another individual with the same condition might be okay with an NSAID alone. So a lot of it is individually based as far as whether acupuncture alone is beneficial or whether it should be combined with something else. The majority of the cases that I see, I am combining acupuncture with traditional therapies, or pardon me, not traditional, but Western therapies. So I am combining our medications with acupuncture to create success in a patient. As far as the mechanism, the stimulation of the acupuncture points, so whether we're using needles or pressure, we're actually activating specific areas. Those points, and this is probably one of the things that I find most fascinating about acupuncture, is that the points were described thousands of years ago, and the language surrounding acupuncture was used for thousands of years. It's really only been in recent history that we've discovered that there's actually something to these points. So although they were described thousands of years ago, these points have something to them. The points themselves are cutaneous areas with high concentrations of A delta and C fibers. They also have high concentrations of mast cells as well as capillaries and venules. So when you place a needle in a human, you can actually get a very, very localized area of mast cell histamine release. So you can get a little bit of redness right around the point of needle insertion. Sometimes you can actually also get a little bit of bleeding at the site, secondary to the capillaries and venules. But again, most importantly are those high concentrations of nerve endings. Additionally, the acupoints themselves have decreased electrical resistance, so increased electrical conductance. They're areas that anatomically are a little bit different than the skin around it. And so those points are unique from other areas of the body for sure. So how do we create analgesia or therapeutic effects when we place a needle? How does that happen? And these are the things that we know. Acupuncture can decrease muscle spasms. So this is actually a picture of me with my hair straightened for the day. But this is a picture of me having trigger point therapy. And although trigger point therapy is a little bit of a different technique, it still uses some of the sort of theories of acupuncture and how acupuncture decreases muscle spasms. So for years and years, acupuncture needles have been placed in areas of intense muscle tension, so knots within the muscles, and we'll place needles directly in those spots. And we know that that can actually decrease the spasms that are occurring in those muscles. It's actually why now physical therapists will do dry needling. They don't call it acupuncture because they're not actually targeting the nervous system so much as the muscular system. But they will place acupuncture needles and actually use acupuncture needles and place those in different body tissues. So the muscle spasm part can be significant for relief of pain in animals or humans for that matter. More importantly, we know that acupuncture induces a release of neurotransmitters. So that's where acupuncture really has its effects. So when we place acupuncture needles, we know that there is a release of endorphins and dynorphins that help produce this analgesic effect. That analgesic effect has been proven to be reversed by administration of naloxone. So release of those endogenous opioids and relying on the endogenous opioid system is a huge component of acupuncture's effects in the body. And as I said, we know that we can reverse those effects just by the administration of naloxone. One of the things that I should point out is that with the muscle spasms is that one of the things that we do with acupuncture needles, and it kind of, we'll get into it a little bit more, but one of the things that we can do is we actually place a needle, and then usually the acupuncturist will spin that needle, and you'll spin and you'll spin, and eventually you can't spin it anymore. And that's because the tissues actually grab on to the needle itself. And what we know is that that centimeters away from that needle, the fascial tissue actually relaxes. So we're actually stretching and relaxing the fascial tissues as well. So as I think of nerves and muscles being enveloped in this, in these fascial planes, we're actually relaxing that and allowing for more natural movement of the muscles and transmission through those nerves. One of the theories for acupuncture's analgesia goes back to Melzack and Wall, the gate control theory, with just looking at the physiology of pain, that if by targeting the fast pinprick A delta fibers by the stimulation with the needles, we actually induce the release of endogenous opioids, which then close the gate, if you will, for the more pathologic C fibers. And so that was something that was used for a long time to describe how acupuncture produces its analgesic effects. And I still sort of like the idea of that when I describe it to students and even owners, things like that, to try and describe how we're actually creating analgesia. Pardon me. So the points themselves are in veterinary medicine are based on translational from human medicine, and they're based on meridian theory of human acupuncture. And so all of the codes or the namings are the same as those used in human acupuncture anatomy. And we use some sizing based on the size of the animal. But for example, if you see there's the internal portion of the tibia, so of a hind limb of a dog, and if I know that there are 13 Schwen from the tibial plateau to the medial malleolus of that tibia, and I'm looking for a point that is 3 Schwen directly above the tip of the medial malleolus on the posterior border of the tibia, then I can use that 13 Schwen and say that it's going to be roughly 25% up the distance of that limb on the internal side of that tibia, whereas on the external side, it's going to be a different Schwen, but these Schwen are based on the rib width. And so everything is translatable from human anatomy. And I can find that point, the spleen 6, for example, I can find that on a dog, on a Chihuahua versus a Great Dane versus a cow, based on these anatomic descriptions, and basically have found it on everything, even up to birds. So just using these descriptions, they really work across species. Again, you can use something called a point finder. Because of that lower electrical resistance, you can actually use something that looks for electrical resistance along the skin, and it will actually just make an audible tone when you find areas of lower electrical resistance. I'd say that might be nice in the early phases of learning the points. What's difficult in veterinary medicine is that as soon as you incorporate hair or fiber, it doesn't work anymore. So it's great on people, but not so useful in veterinary medicine. So how do we use it? In chronic pain states, we would want frequent treatments initially. 3 times the first week, 2 times the second week, et cetera, et cetera. And looking at it, there is an additive effect with acupuncture. So as you do it, you are getting increased effects with every treatment. So 6 to 8 treatments before making an assessment. Usually that's based on, unfortunately, owners' availability to bring them in and their finances. But I usually say that they have to give it at least 3 or 4 treatments. And what you're really doing in chronic pain is you're bolus dosing in the beginning, and then you're able to taper them off so that hopefully you can progress to a point where you're seeing them every 2 to 3 weeks for chronic pain, and should ideally not have to see them more than that. But it's really individually based, and how severe or how much pathology is underneath what's going on. Electroacupuncture is simply, I said we'd get to this, is simply stimulation of the acupuncture needles using an electrical stimulus. So I actually have a unit and I put on what I refer to as my Barbie jumper cables. And I actually attach those directly onto needles. And I can put a low-level electrical stimulus between these needles, and it will enhance the effect. So stimulation of the needles creates a more profound effect. I usually just tell owners that by adding electro on, I am just adding a highlighter to their acupuncture treatment. So that used to be done by just acupuncturists would rotate the needles, or if anybody has had acupuncture, sometimes people will come in and they'll flick the needles to create that stimulation. But obviously an electrical stimulation is much more consistent and repeatable as far as the effects. Individuals that would do the rotating eventually developed a lot of carpal tunnel. So the electrical is much more consistent. But we know that adding the electrical stimulation on is going to enhance the effect, because it also enhances or adds to the neurotransmitters that are released. So when we're doing needles alone or dry needling, we are working with the endogenous opioid system. As soon as we start adding on electrical stimulation, we start getting things like release of serotonin and norepinephrine. And so we're working with many more neurotransmitters along the pain pathway to influence or inhibit that pain response. This study that was looked at as far as the electroacupuncture on persistent pain found that the addition of electroacupuncture has release of several different inflammatory or excitatory neurotransmitters. Pardon me, let me make sure I said that right. The addition will actually release more neurotransmitters that will have an inhibitory effect on pain. So make sure I said that correctly. So why don't people recommend acupuncture all the time? It's because acupuncture has some history and some differences with Western medicine that people have a hard time kind of wrapping their head around. So traditional Chinese medicine includes acupuncture, but actually has 5 different arms: herbal medicine, massage, which is not a relaxing massage. It is actually a very intense body work session called Tui Na. Exercise, Qigong, is similar to like Tai Chi, where it's very mind-body focused, and then food therapy. Traditionally speaking, acupuncture goes back 3,000 years in writing, but as much as 5,000 years with artifacts. So it's been practiced for thousands and thousands of years. And in the traditional basis, it's that there's decrease or increase of energy flow or qi along these hypothesized channels or meridians that are the basis for disease in the body. The meridians themselves have never been demonstrated to exist. And in this slide alone are 2 reasons that individuals have a hard time talking about acupuncture. And it's qi and meridians. But what I would bring up is that meridians have never been proven to exist, but their existence or their talking about a meridian is very interesting because they actually follow connective tissue planes and or nerves in the body. So although the meridians themselves, there's not an anatomical structure that is a meridian, the meridians follow anatomic structures. So talking about them, we might as well say, we could talk about the lung meridian or the lung channel that follows these fascial planes. So just using different language. The other is qi. And I like talking about this with the medical community because qi is this mystic word, and what does it mean? And qi is actually comprised of many different types of qi. And on the right-hand side, we can sort of follow down. It says food, and it goes down to something called gu qi. And that is the qi or energy or health that one receives from food. So when you talk about qi, you're actually talking about all these different components, like the energy that you get from food. So my kids know this. If you eat healthy, you're probably going to feel better than if you eat junk food all the time. That's common sense. And that's gu qi in and of itself. There's also wei qi, which is your immunity. There's also qi associated with the environment. If you live in a heavily polluted area, your qi is more deficient than someone who lives in a really clean environment. So qi, although it has this mystic sort of connotation with it, It's actually just a component of all these different types of or areas that we talk about with health and good health. So immunity and pollution and food, energy. So when we talk about bringing chi to an area of the body, we're really just talking about bringing good health to that area. So what we did with the, in the interest of time, I'll talk about this a little bit briefly, but one of the components that becomes difficult with giraffes in particular is that giraffes can, because of this long neck, they need to be massaged when they are anesthetized to keep those muscles from tightening up or subluxating the vertebrae within the neck. And so one of the things that we suggested was, let's try doing acupuncture on the neck to see if that will keep, have something that is a little bit more manageable and consistent for the personnel, but will keep those muscles nice and relaxed throughout the procedure. So we incorporated that in our patient, our giraffe patient stretch. So.
Well, that was great. Thank you both so very much. We have a few questions here in the chat. Again, if anyone else has additional questions, please go ahead and enter those now. Since we've been speaking about the acupuncture, we have a couple questions relevant to that. One, I think, can be kind of quick. What amperage do you apply to your acupuncture needles then when you're using them?
Yeah, so it actually depends on what you're targeting. There are different, so an 80 and 120 alternating current, Hertz alternating current is usually a pretty standard, but you can actually go very low if you're targeting the nerves versus muscles. And so you can actually play around with it. And there is not a wealth of literature on what the perfect voltage is on the needles themselves. So a little bit of it is trial and error with individual patients.
Fantastic. And thank you, Dr. Tan, for that question. And then Dr. Louis was wondering, complication management. So in the process of performing acupuncture, if you were to cause nerve injury, vascular injury, something like that, how is that something that you would identify? And then ultimately, what would your management of those complications be?
So the points themselves should not be anywhere near large vessels or large nerves. So coagulopathy would be a contraindication. So avoiding anything like that. Now, the needles themselves are so tiny that they actually fit within probably a 25 gauge hypodermic needle. So they would fit through the actual part of the needle. And so the chances of actually causing any trauma to the nerves. Now, if you hit it directly, of course, you can cause some nerve reaction, but it's not like even doing neuraxial or any sort of peripheral nerve blocks where you're looking at a hypodermic. So the reports are almost non-existent of any sort of nerve injury or vascular injury with acupuncture.
That is great. All right. And then to follow up, Dr. Schroeder, there is a regional anesthesia question here. When you look to dose your peripheral nerve blocks or your fascial plane blocks with local anesthetics, how do you dose the local anesthetics? Is it different for different species, different for different sizes? Things like that.
Great question. So a lot of our techniques are going to be based on kind of some initial cadaveric studies, and most of those have predetermined the volume of injectate that's needed. So an example would be, a rectus sheath block. So it's usually 0.4 to 0.5 mLs per kilogram. So we'll kind of find our total volume of injectate, and then we'll kind of back calculate based on your actual local anesthetic. So most of the time we use bupivacaine. We do about 2 milligrams per kilogram. Sometimes with ropivacaine, we'll go up to about 3 milligrams per kilogram, and then we'll just dilute accordingly. So some of our peripheral blocks, maybe 0.2 to 0.4 mLs per kilogram, and then we can split the difference. We as veterinarians are so used to dosing on a per kilogram basis. The concept of patient X gets this many milligrams is really foreign to us. So I would say it's kind of second nature for us to dose on a per kilogram basis and then tailor, dilute accordingly. Most of the time we're using 0.5%, but sometimes we need to dilute out.
That's great. All right. Now, one question I have is when you are assessing these veterinary species, how do you tell that they're in pain? And then, beyond that, how do you tell, or how do you determine that, your intervention has been successful?
There are a number of different ways. We can't really reliably use the visual analog scales. There's not going to be on the clinic wall the 0 to 10 pain score, because it can't really tell us. It becomes very subjective if we try to be somewhat anthropomorphic and put ourselves in their pause, so to speak, and say, yeah, their pain's probably a 6, because that's what I would be feeling. We try to be slightly more objective. There are a couple different pain scales available, one of which is out of Glasgow that's very commonly used, and they're kind of interactive pain scales, and they're grimace scales, for instance, that kind of look at facial structure and facial carriage. So there are a bunch of different validated pain scales that are typically used, and those are typically used in the literature, and then you can do your intervention and then reassess.
And then Dr. Snyder, on an ongoing basis, in those patients that have, more chronic pain conditions, how do you evaluate the efficacy of your procedures?
So it becomes really hard because we have not only, we talk about not only a placebo effect. Our patients don't really perceive a placebo effect, but we do with our owners or even the people that are administering those things, and we call it caregiver bias. So if the owners believe that acupuncture is going to work, they're going to perceive that acupuncture is working in their patient. So similar to a placebo effect. So I start to look for what I refer to as the tangibles, but things like, so I'll have owners that come in, oftentimes with chronic pain, that the dog no longer is able to jump on the couch, get on the bed, has a very difficult time getting up from lying down onto getting up from that position to a standing position. And so we look for things like that. Like I will ask again and again, and what owners come in and say is they can jump on the couch again. They haven't jumped on the couch in 8 months, and now they're getting on the couch again. So they're looking at these behaviors that have gone away, and now they're able to do again. And so then I'll start to ask it more repeatedly as we move on. You said last time that getting in the car is more difficult. How is that going now? So looking at things that are a little bit more indisputable.
All right. Well, I think unless anyone has really any last minute questions, this is going to bring us to a close. I would like to thank Dr. Schroeder, Dr. Snyder for attending here and speaking with us tonight. I'd like to thank Heidi Border for putting this together. All of this could not happen without her efforts to coordinate these things. I'd like to thank all of you for attending. And then for any of our veterinary colleagues who are attending, please, make sure that that ASRA is a welcoming environment, and you are certainly welcome to attend our annual events. And I would love to see you there. And with that, have a great night. Thank you very much.
Thank you.
Thank you.